schedule questions. So therefore, what I've done is I've opened Facebook to see the questions, because it was posted on Facebook what the questions were. We joined too soon. Do you know what? I don't know what I'm doing, to be quite honest with you. I'm getting the questions from the Facebook post itself, but the Facebook post was posted by, was it posted by this software? Yeah, so it must be on here somewhere, but I can't find it. Anyway, there you go. You live and learn. So I don't know. There you go. That's what I'm doing. I'm doing it, and I think it's working on Facebook and on, well, I know Instagram's never a problem. Instagram just ticks away. You haven't got all of the little things where you can write on the screen, but it ticks away and it just works. I don't want to disrespect Facebook. I do not want to do that, because obviously it's a big company, but to be fair, maybe it's this system I'm using. Okay, anyway, let's go. Without further ado, there are some questions which have been posted on Facebook. Don't know if they get posted on Instagram as well. Do they? I think they do, actually. Yes, they do, don't they? So I'll go through those questions. But if you've got any questions, please ask me as I go along, because I don't know how long it might not. I don't know how long it will take me to get through these questions. But anyway, let's just see how we get on. So the first question, again, I was trying to look for the background of these questions and failing. So there you go. The first question says, what should I expect post-operatively? Now, that's a little bit of an open question. What should I expect post-operatively? Well, it would be nice to be a bit more specific about a particular operation. And I guess, broadly speaking, there's two types of operations at the clinic. There's minor procedures, which are moles and cysts and earlobes and nipples and things like that, nipple operations. And then there's major procedures, which are things like breast implants, tummy tucks, breast lifts and things like that. So for a minor procedure, you'll slow anesthetic, walk in, walk out while you wait, mole removal while you wait. What do you think? Big sign outside, big neon sign outside the clinic, mole removal while you wait. Toying with that idea, narrow. Anyway, so those things are done while you wait. Maybe, of course, you can, Miss Karina Bean. Of course, you can ask questions. Yes. Oh, Donatella's in the house. Hi, Donatella. How are you doing? So there's minor procedures, which are local anesthetic, in and out, and then you walk out the door, and for most things, you can probably go to work next day. If it's a mole or something on your face, you might have stitches or something like that, so you might not be comfortable doing that, but you certainly, be okay straight off the bat. If you have stitches and dressings, we normally do them after about a week. Take those dressings off, and the area is a bit red to start off with. So that would be a minor procedure. Major procedure, now I think about it, there are quite a lot of similarities now I think about it, but a major procedure, you wouldn't be going back to work the next day. You'd need normally a couple of weeks off for most things. Things like a tummy tuck and what have you can be a bit bigger, so maybe I normally say 2 to 3 weeks off, and a bit uncomfortable to start with, swollen up and down, shapes, especially with the breast surgery, shape's not right, but even with the tummy and things are swelling or what have you. And then, so to be honest, actually thinking about the similarities, I mean, there are similarities in terms of post-op regime, because it's pretty similar what we do in the clinic, and that is 1 week dressing, 6 weeks with me to see how you're getting on, talk about the scar management, etc., because the scar will be red and firm at that stage. Then 3 or 4 months, then 6 months, then 12 months, then yearly. So that's actually for pretty much anything, but you might be fine earlier than that, and you might not want to keep on coming back. So you don't have to keep on coming back, but we offer it to everybody. We offer everybody a yearly appointment to keep in touch with them. So a bit worse than that with the major stuff. The stuff. I feel like that's been a really lackluster answer, but maybe I shouldn't say that. Don't put yourself down, Jay. Keep going. Yeah, we are on air. Okay, this is happening. This is live. There's no second chances. Okay, so that's the answer to that question, and we're just going to go with it. I can't put the questions up on the screen because I can't see them on my thing. So we're just going to go with it. That's the best I can do on that one. So that is the answer to that question. Good. Right. Kim, and Instagram's got questions, which is awesome. And Kim has just asked a question on Facebook. So I'll do Kim because it's a relatively quick. I think, when can I go into hot tub after tummy tuck, please? So I'd be a little bit careful with a hot tub, Kim. What I would say, a bit like a swimming pool, really. So I would say that you will need to be dry. You need to not have any dressings. Basically, your wounds need to be dry. But even if you do have dressings, sometimes you have little bits that don't heal up so well, and you get a little bit of sort of staining or exudate on your underwear or on your clothes. So if you're still at that stage, if there's anything a bit wet, a bit weepy, then I wouldn't get in your hot tub. So once it's all fully healed and you've got no dressings on, that's the sign. I'm going to say 6 weeks would be reasonable for that, but you'll probably be there before then. But it's talk to your surgeon, Kim, because Kim Killick is not a name I recognise, although you might be under a pseudonym. I know what you like on Facebook, but if you are my patient, give me a ring and I'll let you know, because I'll know you. But if not, talk to your surgeon. But yeah, just when everything's all totally dry, what have you. Losing track of the Instagram. What's going on? So we've got a question earlier on Instagram, but that's okay because I can scroll. I'm a scroller. Here we go. Okay, I'll do one. Well then, do one. Yeah. I am considering having breast implants, and it's scaring me reading girls saying that their bodies have rejected them. And I wanted to know your take on this, please. Yeah, that is scary, Amy. So my take on that is that breast implants don't get rejected, Amy, to be quite frank with you. So, but rejection in a medical term is your body reacting to the thing, and it refers to tissue, because the tissues have antigens, and your body has antibodies, and your body will attack anything that's not itself. So it refers to things like kidneys, or lungs, or a tissue that you're putting inside your body can get rejected if the antigens on the tissue are not recognized by your body as being part of your body. That's why you have to match people and things when you do transplants. So rejection doesn't happen with breast implants. Breast implants don't have antigens. They're just silicone. They're inert. But what does happen with breast implants is infection. And I think when people say their body rejected their implant, what they're talking about is they got an infection. Infection means it gets red and angry. The wound might open up, and sometimes the implant can be visible, and it looks like the implant's sort of coming out almost. And they think, oh my God, my body's rejected the implant. It's terrible. It's infection. It's very rare. I've got to be honest with you. It is very rare. But it is probably, I would say, the big thing that we worry about with implants. It is the big thing that we worry about because it is significant. Because if you get an infection, you have to remove the implant, and then you can put one back in a few months later. So it is something we worry about. And I've got to be honest, Amy, there's other things you've got to worry about with implants as well, not just infection. There's capsular contracture, which is going hard. In the future, there may things happen in the future that might need upkeep. So there are things you have to be aware of. And what it's all about, Amy, it's balancing them. It's balancing the risks versus the benefits. Because if you think, oh my God, infection, that sounds terrible. It is terrible. It's awful because you have to take the implant out. You have to be without an implant for a few months. Don't want to go through that. As I say, it's very rare, so you have to put it into perspective. But that's fine. Then don't have implants. If the risks are too high for you versus your benefits, because the benefits are very personal of this sort of surgery. It's a very personal choice. And so if you're thinking, you know what, I quite like implants, but take them or leave them. I'm quite happy with how I am, and it might be nice to have them. And then we start saying, well, you can get infection, you can get capsular contracture, you get all these problems with them. And you might think, oh, crikey, back off, and then don't have them. So it depends on the risks are the same for everybody, and there are quite a lot of things that can go wrong with implants, but they're all very rare. So when you come to see us, we'll tell you all these things that can happen, and all of them are very rare. But still, we have to tell you everything, and you have to make a judgment as to whether that is a risk you want to take. So I don't know if that's been helpful. Maybe not. But anyway, things can go wrong with implants, Amy, and but not rejection. It's infection that they're talking about. But as I say, it's a very rare complication. Katie Sarah, for over What's happening? We've got a bit of both. That's what I want. This is the interaction we need. This is I've made it. I've broken it. Right, Katie Sarah. For over the muscle breast augmentation, how long would you suggest having off work, and how long until you can drive? Thank you. So Katie Sarah, very everything that I say is obviously sort of generic for everybody. So everybody's different. After a week, I think you'll be feeling better. It is a bit better when it's over the muscle compared to under the muscle. Under the muscle is a little bit more uncomfortable and takes a little bit longer for things to settle. So I think you'll be feeling better after a week, and you will probably be doing stuff working from home and things. Will you be able to drive? Maybe. I'm sorry to not be too clear on that, but I would say 2 weeks is safer, Katie. Obviously, if you work for yourself, you probably will be going to work in the second week. But if you work for a company, you have to tell them whether you're going to be back or not. Sometimes it can be a bit annoying if you say, I'll be back after a week, and then after a week you think, oh my God, it's really hurts and I'm not ready to go back. So it's safer to say 2 weeks, but you might be okay after a week. Everyone's different in terms of driving. And so therefore, did you say driving or did I? Yeah, you did say driving. So everyone's different, and it just depends on how you recover. So 2 weeks would be safer. You might be able to go driving after 1 week, and again working the same. So two weeks, once you're driving and you're feeling better, you're still going to be a bit sore, still going to be a bit swollen. No heavy lifting for 4 to 6 weeks, but if your work doesn't involve that, then you should be okay doing that sort of thing. Khan says hello. I don't know if I've said hello to you, Khan. I don't know if I've acknowledged that comment or not. Can't remember. It's all a bit of a blur of what happened earlier on. Kim Killick says, I'm looking into having a tummy tuck. Awesome. Good. Well, Kim, if you've got any questions, you know where to come. Amy, where are you based, please? I am based in Edgbaston in Birmingham. I have a clinic in Edgbaston, just near Five Ways Roundabout. I don't know if you know where that is. But that's where it is, quite central, and near Five Ways train station as well. Anyway, Miss Karina Bean, should you avoid elevating a breast IMF, inframemory fold, if there was not a big difference between the two IMF heights? What issues can arise if this procedure is done during a BA? Interesting question, Miss Karina Bean. Normally, for someone who has not had surgery, if you're going to do anything to the IMF, the inframemory fold, so the IMF, ladies and gentlemen, is the fold where your wire of your bra sits. It's where your breast meets your sort of abdominal wall, and it's a very important landmark. And if we're going to do anything to the IMF when we're doing a breast augmentation, it's normally lowering it. So I'm trying to think of a situation where you'd raise an IMF for a primary breast augmentation, and I can't actually think of one. If anything, you often need to lower it, because if you kept the IMF, if you kept the fold where it was, if you look at a breast, a small breast, often the distance from the nipple to the inframemory fold is quite short. So if you then put an implant in and respected that same inframemory fold, the implant would sit too high, and it wouldn't be centered on the nipple. It would be all implant above the nipple and no implant below the nipple. And so it would look like the nipple's sitting low. So you often have to lower the inframemory fold to center that implant on the nipple. So that's actually quite common with the breast implants. And if you've got a discrepancy between inframemory folds, it's easier to lower an inframemory fold than to raise one. So everything else being equal, probably I would lower the higher inframemory fold to match the other side, rather than raising it. Now, you can raise an inframemory fold, and you're normally raising an inframemory fold for people who've had surgery and where the inframemory fold's been made too low and the implant's sitting too low, and therefore you need to redefine it or bring it back up. So that'd be the normal situation. What issues can arise if this procedure is done during a BA? So it is difficult to raise an inframemory fold, to create that landmark. It's something when you're doing breast reconstruction, when someone's had a mastectomy and got nothing there, recreating that inframemory fold is a very important part of the surgery, because that's obviously a very important part of getting a nice breast shape, rather than just a mound of tissue that sits on the chest. You want to get that nice breast shape, and that inframemory fold is crucial to recreate that. So it is difficult to recreate the inframemory fold. You have to use long-term, or I use you don't have to, I guess, but I use long-term dissolving sutures to try and tack down and recreate that fold. It can give a little pinched appearance when you first do it, but those sutures do dissolve over a few months, and And what are the issues that can arise? Well, I guess the main issues are that those sutures dissolve and the inframammary fold drifts again, and you don't get a nice definition of the fold. That's the main thing that I would worry about when raising a fold. It's a hard thing to do, and there's a risk of the deformity recurring. It's a good question, Miss Karina Bean. I hope I've answered that. Please feel free to come back at me about that. Woohoo! Someone who got my name right. Amy, oh, did I? Blimey. Thank you so much. Very. Yeah. Katie Sarah, thank you. I'm going to do a couple of waves. Right. What's my next question? I'm looking at my list here. What should I say? We've done that one. Do I have to be 18 for mole removal at your clinic? So the important words there on that question is at your clinic. So yes, you do have to be 18 to have a mole removal at my clinic. You don't have to be 18 to have a mole removed. You can have a mole removed at any age, but there are very strict guidelines, is that the word, or policies, procedures for dealing with children. And I know you might say that 17 is not a child, because some 17-year-olds are bigger than me. Probably quite a lot of 17-year-olds are bigger than me. But anyway, that's what it is. And then in the eyes of the powers that be, so we're not going through those hoops, even though, to be honest with you, we've got a pediatric surgeon and we've got a pediatric nurse. So we're probably one of the most well-suited clinics to treat children, because those are probably the most two difficult aspects to fulfill. But nevertheless, we have just made the decision that we're not going to go through all the safeguarding and all the issues that we would need to do to treat children. Because it's a very small part of what we would do anyway. And so yes, you do need to be 18 to come to the clinic, but you can go to your local private hospital and be treated if you're under 18. Although again, they have very strict guidance, and it's difficult for them to. I feel sorry actually if you 15, 16, you got a mole on your face, which is easy to remove under local anesthetic, easily done. But quite hard to do it because of all the sort of red tape around treating children. So yeah, unfortunately, we only do 18 and aboves children, people. Is tummy tuck a good way to lose weight? No, of course not. No, it's not a way to lose weight at all. Tummy tuck is not a weight loss procedure. Tummy tuck is a procedure to remove skin and fat, mainly skin, to contour your abdomen after you've lost weight. So if you want to lose weight, if you win the lottery and think, right, I'm going to have a tummy tuck, forget it. Because if you then went on to lose weight after having a tummy tuck, you'd have loose skin. And if you are heavy, if your weight is high, you are going to not get a good result from your tummy tuck. It's not going to, you're going to increase your risk of complications, and it just doesn't look good, because a tummy tuck, yes, addresses the central abdomen, but if you're sort of carrying a lot of weight elsewhere on your frame, tummy tuck doesn't do anything about that. So it can look still a bit sort of round, especially if you've got a intra-abdominal fat inside your abdomen, which can't be addressed with a tummy tuck. So you can get a sort of rounded or sort of a barrel appearance to your abdomen. Doesn't look good at all. So yeah, it's not a weight loss procedure in any way. There is a whole other branch of surgery involved in weight loss called bariatric surgery. It's a different type of surgeon. It will be a general surgeon who'll be trained in bowel surgery. General surgery sounds general, but it's not. It's specifically or mainly bowel surgery. And that would be a whole different, that's like gastric bands and sleeves and all bypasses and all that sort of thing. So that's not plastic surgery. We deal with people after they've lost the weight, when they've got the skin, too much skin, and we tighten the skin. So that's what a tummy tuck does. Tummy tuck tightens the skin once you've lost weight. I'm getting hearts coming up on Instagram. That's very, very reassuring. I don't know whether it signifies something, but it's just reassuring. So thank you for that, however that is coming. After mole removal surgery, how long will the area be red for? Yeah, okay, so there's, broadly speaking, two ways you can remove a mole. One is to shave it, which gives you a red patch, and one is to cut it out, which gives you a line. Call it what you will. They're both scars. All right, let's not beat around the bush here. We're talking scars. All right. I know people think, what? I'm gonna leave a scar. Well, I can call it something else if you want. I can call it a mark or a line, but yeah, it's a scar. If you remove a mole, it's going to leave a scar. People say, oh, you do it by laser, you don't leave a scar. You're like, well, yeah, no, if you're going to remove a mole, you've got to destroy that tissue that the pigmented cells are in, and that's going to leave a mark. I don't know what, it's a scar. Sorry, it's a scar. Now, often the scars fade so well that you can't see them. Doesn't mean they're not there. You look really closely, you might be able to see a little white thing, but you can see a mark there. So yeah, when you remove a mole, it's going to leave a scar. So so how long will you be red for? I normally say 3 to 6 months. Now, obviously, it's variable, but the main reason that you've got to be aware about the redness is because you don't want to get a tan on it. This is something that's very important, especially if we're going to get into some good weather. We don't really want to get a tan on a red scar. If you get a tan on a red scar, it will pick up that pigment and it will stay pigmented. You'll end up with a pigmented scar. So that's the first 3 to 6 months. Again, a bit like the post-op question, it depends on different people. So 3 to 6 months is sort of normal. Sometimes 3 months is gone skin colored. Sometimes it's still very red at 5 months. So I normally say about 3 to 6 months that it remains red. And massaging it can help it to settle. And really, a year you're probably you're looking at it looking pretty good, but it can be a bit red for the first 3 to 6 months. Drag, thank you for the knowledge deserves a heart. So it's you, my friend, who is doing the hearts. Thank you for that, very much appreciated. And Olivia Paul's X has joined. Olivia Paul's X, or is that Olivia Paul's X? Anyway, what's the difference between a breast lift and a reduction? Well, the difference is they're very similar procedures. And when you ask, if you ask for a post-op, not a post-op, a guide, we got guides that you can get from the website. If you ask for a guide, I've done guides with frequently asked questions. I've bundled them together. It's a bundle, so it's breast lift stroke reduction. So it's just one guide because the sort of scarring and the complications and a lot of it is very similar with a breast lift and a breast reduction, because basically they're both reshaping the breast, and a breast lift is removing skin, tightening the skin envelope, rearranging the volume of breast tissue that you've got there and moving it higher up onto your chest. Breast reduction is exactly the same. So a breast lift is part of a breast reduction, but at the same time, you remove some of that volume. So you take some of the weight away from the breast. It is good, if you want to be smaller, obviously. If you want to be smaller, then it's a reduction you want, not a lift. A lift, you're broadly speaking the same sort of size. But B, when you do a lift, if you have got big breasts, that volume of breast, that weight of breast will still be acted on by gravity and will droop over time. So if you do have a reduction, particularly if you can take some volume out of the lower pole, if the lower part of the breast, it can make it less heavy to make it less likely to droop. So it'll give you a more long-lasting result. But obviously, you've got to be happy being a bit smaller. If you don't want to be a bit smaller, then it's a lift you want. Very simple question. So I normally say to people, well, hi, how are you doing? Can I help you? Yeah, I'd like my breasts to be reshaped. No one says that, but let's just say they said that. Okay, well, two things: size, shape. Are you unhappy with the shape? Yes, I don't like the shape. They're droopy. They've lost their shape. I've had children. I've lost weight. Whatever. They're droopy, and I don't like the shape. Okay. So, are you happy with the size? So that's either yes, I'm happy with the size. Well, that's a lift. Or no, I'm not happy with the size. Okay, I need to draw out a thing. Yeah, no, not happy with the size. Okay, well, they're too big or they're too small? They're too big. Well, if they're too big, then it's a reduction. If they're too small, then it's a lift and implants. So if you're unhappy with the shape, it's a lift. If you're unhappy with the size, if they're too big, it's a reduction. If it's too small, then it's implants. And if it's shape and size, it's lift and implants. Simple. That's it. I've just given it away. Fortunately, there's no one watching, so because I've just given away the secret of cosmetic breast surgery right there, my friend. That's it. It's as simple as that. People often say, I don't know if I need a reduction or a lift or an implant or a lift with implants, etc., etc. And just by going through those, obviously it's not as simple as that. Obviously there's more to it, you know, because implants can do stuff for the shape as well as the size, etc., etc. But still, broadly speaking, that's it. So a lift and a reduction of the same operation, with a reduction just making them a bit smaller. So the main thing is, particularly if you're ringing the hospital for a price, what I would say is, if you want a reduction, don't say I want a reduction and a lift. Often people will say I want a reduction and a lift. Now I would say, well, just, you know, just quote them for a reduction, because that's how lift is part of it. But if you've phoned up the hospital, you know, pricing line, and you got someone who didn't know about plastic surgery, perhaps, who looked at the price list for how much a reduction costs, and then looks at the price of how much a lift costs, and then adds them together, then you're in trouble, because that's going to be double the price, and that's not what we're dealing with here. You know, it's just one price. It's just a reduction price, and a lift is a part of it. Miss Karina Bean, look at you. Would a sternal notch to nipple distance between 21 to 23 be a measurement that would put you in a category for a breast lift? Sternal notch to nipple, yeah. Look at you, Karina Bean's you know, it's part of the internet, isn't it? Everyone gets into all these technicalities. I'll tell you what, I think a lot of medicine is going to be like Google. Fortunately, plastic surgery is a very surgical specialty, so I think we'll still be in a job. But those people who do specialties where you have to do diagnosis and stuff, you worry that everyone can Google it nowadays. They know what they've got wrong with them, because that's a bit technical there, Miss Karina Bean. But broadly speaking, and this is personal, so on a personal basis, when people are borderline for a lift or implants, in my head, my cutoff is 24. Snipple to nernal dotch, nipple to sternal notch distance of 24. Above 24, I'd be like, I think you need a lift. I wouldn't go implants. If your nipple to sternal notch distance is less than that, so you're saying 21 to 23, that's not bad, that nipple to sternal notch distance. I'm assuming you've got a problem. So if you haven't got a problem, you wouldn't be here, would you? So let's say you don't like the shape of your breasts, okay, and you've got a nipple to sternal notch distance of 23 centimeters. The next question is, it's the volume. It's the volume that whether you're happy with the volume or not. Because if you are happy with the volume and you don't like the shape, then it's just a lift anyway. Because the only thing that I would think of, if you had a shorter nipple to sternal notch distance, 21, 23, and you were unhappy with the volume and you want to be bigger, then an implant can take up the slack, if you like, and sometimes avoid the need for a lift. So there are patients, in fact, I'll say there are patients, nobody wants a lift. I was going to say there are patients who don't want a lift. Nobody wants a lift, to be honest with you. Nobody wants a scarring with a lift, but a lift is really good at tightening the skin. So people say, I don't want a lift. I'm like, well, you know, you could do with a lift because your nipples are sitting a bit low. But if you actually say, I want to be bigger, you'd have to want to be a fair bit bigger, because that implant needs to take up the slack and fill the skin. Then it might be possible to just use implants and avoid a lift. It probably won't be quite, or it may not be quite as good as doing a lift, because a lift would actually lift the nipple and might make the shape a bit better. But you might say, look, I don't want the scarring and the complications associated with the lift. I'm happy to live with the nipple sitting a bit lower. You look great in clothes. Out of clothes, you might say, nipple's a bit low. Wish it was a bit higher. But there is a category of patients there who have the nipple to sternal notch distances of less than 24, who want to be bigger, who can get away possibly without having a lift if they want a certain volume of implant, because that will sort of take up the slack, if you like, and avoid the need for a lift. I don't know if that's where you're going. What you come back here, if that's the measurement with an implant. So with an implant, that measurement doesn't change. So when you do the nipple to sternal notch distance, when you put an implant in, it does get higher. So it appears that the nipple's being raised, but it's not. The position from that sternal notch, that bony landmark, if you're not doing a lift, that position doesn't change. With a lift, it changes, but with an implant, it doesn't change. So it doesn't change with an implant. I hope I'm on track with you, Miss Karina Bean. I hope I haven't gone too technical and too off track. I do tend to do that sometimes, to be fair. So feel free to come back at me. Meanwhile, Danny's in the house. Big up yourself, Danny. Could you do a reduction and an implant rather than a lift to avoid the lift scarring? No, Danny, because the scarring with a reduction and a lift is the same / similar. You might have a slightly longer horizontal portion to it with a reduction, but the pattern of scarring is the same, because a reduction and a lift both lift the nipple. And if you're lifting the nipple, that means you're making a scar around the nipple and then taking some skin out. So there's always a scar around the nipple. For me, a reduction and a lift, there's always a vertical component to it. So the so-called lollipop or circumvertical scar is an absolute minimum. And there's often a scar in the fold there as well, horizontal scar, short T, or maybe even a full anchor if you're having a big breast reduction. So the scarring is the same whether you're doing a reduction or a lift. So yeah, so you couldn't do a reduction and an implant rather than a lift to avoid the lift scarring. No, I hope that's... Okay, Danny, feel free to come back at me. Miss Karina says, Fabs, thanks so much. Good. I hope I've explained that. We got Nicole over on Facebook saying, how long is the time for a breast lift? The healing time for a breast lift. So yeah, I mean, the thing about a breast lift is those scars that meet. So it says it goes around the nipple, then down, and there might be a horizontal portion. And whenever two scars meet, particularly that T junction at the bottom, there is a risk that the scarring might take a little bit longer to heal. But still, thinking about it, it's pretty much any operation that I do, I aim for the scars to be healed in a week. So your dressings will be on for a week, and I aim to be healed in a week. But for a breast lift, to be honest and to be completely fair, they're probably not going to be completely healed in a week. There's probably going to be a little spot of this or that, a little bit of blood or things. So we normally give you a bit of gauze to wear inside your bra, and it's probably going to be 2, maybe 3 weeks for everything to be completely dry, and that's where you can start getting in your hot tub or going swimming and things. So I'd say 2 or 3 weeks for the skin to be healed, but then it's 2 or 3 months for the scarring to settle, and it takes months. So I normally say things really start to settle about 3 months in terms of the scarring, the redness, the funny feelings, stuff like that, and they can take 6, 8, maybe even 12 months for them to really properly settle. So it can take a long time for it to really properly all settle. Pratik says hi, and I got a feeling that Pratik is on YouTube. Is this a YouTube comment? Wow, I've got a YouTube viewer. Look at that. I've got a YouTube viewer. I don't think I've ever had a YouTube comment. That is great. That sounds bad, doesn't it? I think I have had comments on YouTube, but not on the live. But hello, Pratik. Is this YouTube live? Does it work? Brilliant. Nice to see you. Miss Karina Bean on Instagram. Is there any risk to your breastfeeding potential with implants placed under the muscle? No. Or over the muscle, Miss Karina Bean? No. Under or over? No. There's absolutely no problem with being able to breastfeed whether you have the implants under or wherever you put them. Assuming you can breastfeed now, that's the thing I would say, because some people can't breastfeed. But having breast implants is not going to affect your ability to breastfeed. Slight sort of rider on that is it does depend a little bit on the incision that you make. So I pretty much always make an inframammary incision, which is in the fold where your bra sits, and I go underneath the breast gland and push the ground forward. Sometimes people will use an infraareolar incision, so they make the U-shape incision on the areola, and there is a risk that some of the ducts might be damaged doing that. So I don't do it, so you'd probably have to talk to someone who does it to say whether that's going to potentially give you a significant risk of problems with breastfeeding. So maybe the infraareolar incision might have a higher risk of problems with breastfeeding, but I don't do it for putting implants in. I use the inframammary, and the inframammary you're not cutting any ducts or anything like that. You're just going underneath the breast and pushing the breast forward, so all the ducts will remain intact. Oh, look at this. Pratik's asked another question on YouTube. 2 questions on YouTube. Right, Pratik, what will the cost for this tattoo excision be? Pratik, depends on 2 things. Size and location, my friend. So a big tattoo in a good location is, that is the cost, but also whether it's a goer, to be honest with you, Pratik. I get several tattoos a day. I think it's fair to say several photos of several tattoos a day, asking for prices. But what percent? 80% of them, I would say. I would say I can't remove, because if you've got a big tattoo on your shoulder, big thing on your forearm, you know, not even that big a thing on your finger, you know, you can't remove it. If it's either a big tattoo or a small tattoo in a bad location, like your finger or your hand, you know, these roses and stuff on the back of the hand, then I can't remove it. It has to be either a small tattoo, or I can sometimes remove a bigger tattoo if it's in a location with laxity. Classic being the abdomen. You know, there's quite a lot of laxity on most of our abdomens. And so it depends on size and location as to whether it is a goer of at all. Backside of my hand, I've got to be honest with you, Pratik, it's not a good place for a tattoo in terms of for excision, because what often happens, I say it depends on the laxity of the skin. So what people do is they say, look at that, there's loads of skin laxity. Look, I can pinch it and I can get all that skin, you know, I can do that. And then I say to them, well, make a fist and the laxity all goes. So, you know, you've got to be able to make a fist. You don't want to make a fist. You don't want to have the thing removed and then you go home and go to make a cup of tea and, you know, go and put the kettle on and your wound opens up. So there's not as much spare skin on the back of the hand. That's hurt me quite a lot, actually, pinching my hand. There's not as much spare skin on the back of the hand as you would think. So, you know, if it's a small one, if it's favorable, so favorable means if it's like in a linear. So often we see people with names and things on this side. That's favorable for excision. And the way that it'll be favorable on your hand is going like that, in that way, because we want to make the scar that way. We don't want to make the scar that way, because if we make the scar that way, and when you make a fist, it will pull the scar open. If you make the scar that way, so if you're accessing the hand, if you're doing surgery on the hand, you make the scar that way. So if by any chance it's an arrow or something on the hand, that might be a goer, but it's pretty rare to have an arrow on the hand. So it might not be a goer. Would a skin graft work? Well, Pratik, in specifically answering your question, would a skin graft work? The specific answer to that is yes, a skin graft would work. But should you have a skin graft? Absolutely not. And would I do one? No, I wouldn't. I wouldn't do a skin graft, particularly on the back of the hand. Skin grafts don't move very well. You've got tendons there, you know, right there. You don't want to tether any of the tendons. They're unsightly. Yeah, I know you probably don't like the look of your tattoo at the moment, but skin grafts don't look good. And on many levels, skin grafts aren't good. So a lot of people say, can you not just remove my tattoo and put a skin graft on it? And I pretty much always say no, because skin grafts don't look good at all. So if I was going to remove a large tattoo, I do something called serial excision, which means taking a big chunk of it out, closing it tight, leaving it a few months when it's had time to relax, and then taking another big chunk of it out. That's called serial excision. But skin grafts don't look good, and in my hands and in my experience, it's not a good way to remove a tattoo, because it trades one thing that you don't like in potentially for another thing that you don't like in, and the other don't like in. Don't like. I don't know why I said in. And the other thing about it, particularly someone on the back of the hand, you'd worry about the functional aspects of it in terms of tethering the skin and the tendons and making you not be able to move your hand as well. So I'd say it's a no-no. I mean, if you had a big skin cancer on the back of your hand, yes, you could take it off and put a skin graft on there. But for a tattoo, I wouldn't recommend it, Pratik. Lovely that I'm getting comments on YouTube. Sorry if I'm not being desperately positive, but I'm trying to be realistic. But Pratik, if you want to email a photo, I'll be very happy to have a look at it. info@staianoplasticsurgery.co.uk. Be very happy to look at it. What's going on? Instagram is kicking off. Breastfeeding, we've done that. Brill, thank you. You're welcome. Danny CXX, what's the recovery for mummy makeover in terms of getting back to normal mum duties? Also, if you have more than one tummy tuck down, you use the same scar. Do you use? I think that is. Do you? Yeah. Okay. So the recovery for mummy makeover in terms of getting back to normal mum duties. So mummy makeover is an abdominal and a breast procedure. So I would normally say that probably the abdominal procedure or the tummy tuck. Let's not split hairs here. We're talking about tummy tucks. It's a tummy tuck, isn't it? The tummy tuck, I would say, is probably going to be the overriding one. And so your breast is going to get, heal while your tummy's healing. So you'll be bent over when you first have a tummy tuck. It is quite a big deal. And you'll be a bit uncomfortable for a good couple of weeks. You may well be. You come back to the clinic after a week, have the dressings off, and you probably be a bit bent over when you come back then. So it'll be a good couple of weeks for being bent over and not really wanting to do mum duties, not really want to be lifting the kids and things like that. I normally say no heavy lifting for 4 to 6 weeks, but it's hard when you've got small children because obviously they'll come and say, "Oh, Mum, can you I've hurt my leg," and you want to give them a cuddle. So you end up just sort of sitting on a chair and then putting them on your knee type of thing. So yeah, but for the first 4 to 6 weeks, it will be uncomfortable and you will struggle a bit if you are, the main carer for your children. So I think you've got to think about that, and it would be good if you had help in the first month or so. If you have more than one tummy tuck, then so if you've already got a scar in the area, then what we would normally aim to do, assuming the scar's nicely placed, is go below that scar and cut it out. Similarly, if you've got a cesarean section, we go below that scar, so that scar gets removed, so you're left up with just one scar. So yes, the scar is removed and you end up with just one scar, so you don't have any evidence of a previous scar. Practice back on YouTube. YouTube's on fire. It's around 2 inches. I had it done on a scar, but now I prefer a scar. 2 inches, yeah, that's big, isn't it? 2 inches on the hand. Back of the hand, that's big, Pratik. If 2 inches is the narrowest dimension, if you like. Yeah, that is big for the back of the hand. So just from what you're saying, it doesn't sound like it's a good one for excision, Pratik. And the thing that I always say to people with tattoos is the first line of treatment is laser. So I don't know if you've tried laser, but that is the first line of treatment. And the people I see have normally tried laser and it's not worked. So, but it's not for every tattoo excision. As I say, the majority of patients who send in photos are not suitable for excision. So, and it sounds like you might be one of them, Pratik. Sorry to be a naysayer. Miss Karina Bean, come on. Holly's waving back at you. Speaking of tummy tuck scars, would a typical C-section incision be at/above/below a TT scar? At, Miss Karina Bean, at. So again, when you have a cesarean section scar, what I do is I go just below that scar because they're usually pretty well placed and they usually settle pretty well. So I go just below that scar and excise it, and then aim for the tummy tuck scar to be the same sort of level as that scar. The only thing is, if it's quite tight, then it can pull the scar up a bit. It can pull it up, but we aim to be at about the same area as the cesarean section scar. If the TT scar was there first, though. Oh, I see. Do you know what, Miss Karina? I've got to be honest with you. I don't quite understand. Sometimes I see people who've had 2 cesarean sections and they've got 2 scars. And I don't really understand the mentality of the surgeon that's done that they've got a scar there and they've actually just made another scar next to it. I mean, I just don't get it. So I guess I would say if you've already got a tummy tuck scar and you're having a cesarean section, I would speak to the surgeon and say, I would just excise that tummy tuck scar, so you only have one scar. There's no need to keep on making new scars. You just excise the old scar and use that for your access. If the tummy tuck scar was first. So yes, as Danny says, the tummy tuck scar is much longer than a cesarean section scar. So they would just be excised in the middle portion of it. So it would look a bit weird. You'd have a fresh middle portion and then, old side bits to the scar. But once that middle portion is, after a year, it will catch up and it will all settle and it will just look like one scar. So I would say you're better off just, if I was doing the cesarean section, which I wouldn't, you wouldn't want me doing the cesarean section because I don't know what I'm doing in terms of that sort of stuff. But if I was doing the access, I would just excise that middle portion of the abdominoplasty scar and use that. But as I say, I have seen people who've had second, so I suspect they probably won't. They'll just pretend it's not there and make another scar above and below it, which doesn't make any sense to me. But what can you do? Pratik, what you got? YouTube, come on. This commenting, Pratik, is brilliant because this is going to now make the YouTube world think, hold on a minute, what's this? Something going on. I bet I'm going to get my YouTube views up. Huh? What if a partial incision is done and then after a few months we do it fully? That is serial excision, Pratik. That is serial excision. That is exactly, you've described serial excision, which I tried to describe a minute ago, which is basically taking a chunk of it out, letting it settle, closing it tight, and then 3 months later it's not so tight, so then you can take another chunk of it out. So that is known as serial excision, and that is a technique that you can use for big tattoos. But it's just, I just think taking big chunks out of the back of the hand is not good Pratik. So send us a photo and I'll have a look, and that might be an option. It does prolong it. I mean, it takes a few goes, but it might be an option. There is a YouTube video out there about serial excision, I'm pretty sure of it. But yeah, that's what you're describing there. Italy is joined. How long after birth is a good time for a consultation for mummy makeover? It depends on how keen you are, Danny, because if you're very keen, then I would say 3 months, and then 3 months with a view to minimum 6 months for doing surgery. But to be quite honest with you, Danny, I normally recommend a year after birth for mummy makeover for 2 reasons. One, to let all your tissues settle, your tummy settle, your breasts settle, especially if you're breastfeeding, let everything settle. But also your child's then a year old and a bit easier to manage. Now, you might say, I've got loads of help at home and I want to have it done sooner because I'm on maternity leave. A lot of people say that sort of thing. So, you know, as I say, 6 months is the soonest you could do it. But I normally advise people to wait a year if they can. So, you know, maybe, you know, if you really wanted to the soonest, I would say consultation at 3 months with a view to surgery at 6 months. But it may be better to, I mean, it doesn't matter when you come for consultation, you can always come back if you can have surgery later on. So you could always come at 3 months and still have surgery at 12 months, maybe come at, you know, 8 months or something. But yeah. Thank you. Oh, you're welcome. What's going on? If a partial, please send me your email. Pratik, I don't know how to send you my email because I can type stuff, but I think it'll come up on, well, I'm going to try it. I'm going to type it. Oh yeah, I can, Pratik. Hi, Pratik. My email is info@staianoplasticsurgery.co.uk. How's that? How's that? That go? There you go. Yeah, it's good, isn't it? So yeah, send us a photo, Pratik, and I'll give you I'll have a look at it, and then someone in the office will give you an email back. They'll drop you an email tomorrow. But thank you for participating. What was that? Was that the thing? How long after birth? Miss Karina Bean, does breastfeeding cause breasts to potentially sag more, or is it the pregnancy/postpartum increase in size cause most of the damage per se? Yeah, I think it's the whole thing that causes most of the damage, Miss Karina Bean. And I think if you want to breastfeed, then you should breastfeed and not worry about it, the consequences. Now, I think even if you don't breastfeed, the breasts get bigger, they get engorged with milk, the skin gets stretched, and you do have a potential risk of the breast sagging. Since you asked the question, the longer they're stretched for, it's like anything. It's like a jumper, you know, you stretch it and then let go, it goes back. But if you stretch it for a long time, you know, if you sit there with your knees in it all the time, it's going to lose its elasticity. So the longer they're stretched for, the more they're going to sag. So yes, if you are breastfeeding for a prolonged period of time, then they're going to stay bigger for longer, and so you are going to increase your risk of it sagging. But don't let that not make you breastfeed, because breastfeeding is good, and if you want to breastfeed, fine. But since you asked the question, yes, I think breastfeeding does potentially cause the breast to sag more the longer you breastfeed. That is a risk. Oh, where are we at? Great analogy. Thank you. Just thought of that just now. Make a note of it, the jumper and the knees. Yeah, thank you. How long does a breast lift last? There we go. How long does a breast lift last? That's a tricky one. I think I've heard a lot of people say 10 years, but I don't know how you can say that really. I mean, what I normally say is that what this stuff does, and it doesn't matter if it's a breast lift or a facelift or whatever, is well, those are the two big ones really, breast lift and facelift, I think, is it resets you to a better place. And then you will continue to age from that place. So it doesn't stop time at that place. It doesn't mean that you have a breast lift and then your breast will stay like that forever. You will still be acted on by gravity. And if you have children or put on and lose weight, which are the two big things that can make your breast droop, that's going to make your breast droop again. So they will droop again over time. Maybe 10 years is a good thing to say. Maybe that's a good, I don't know. But basically they will droop again over time. And if you can look after them and not have significant weight fluctuations and not have children, well, I'm not saying you shouldn't have children, but if you didn't have children, you're going to make them last longer. Is my areola reconstructed in a breast lift procedure? So the areola is the bit about around the nipple. It's the pink bit of skin around the nipple. The nipple's the bit that sticks out. So it's called the nipple areolar complex, NAC. And reconstructed, no. I mean, reconstructed is a term that we use to make it again. So like for someone who has breast cancer, where you take the nipple areolar complex off, you reconstruct the areola, usually by tattooing. There's other ways you can do it by taking skin grafts from the groin area and things which are a bit darker. But it's not reconstructed. Basically, your areola, you cut around the areola. Reducing the areola is an integral part of a breast lift. So you cut around the areola to the size of areola you want, and then you take away all the skin around it, and then you mobilize the breast higher up onto your chest and stitch it back in again. So it's the same areola. It's not reconstructed. It's just moved. When can I wear a normal bra after augmentation? I normally say a month. A month is sort of normal. We give you a post-op bra to wear, and I normally say wear that day and night for a month and then see how you go. The problem with a normal bra after augmentation is that it can irritate your scar. So if it irritates your scar, I'll say, look, go back into your other bra. You might also find that it's still a bit swollen, a bit uncomfortable, so you might want to wear your bra for longer. So I would say a month is a minimum, but you can wear it for longer. If we're going to get into some hot weather and things, people don't like wearing the post-op bra because it's uncomfortable and it's a bit hot and things. So, you know, a month is the minimum, and then just see how you feel, but you might want to wear it for longer, which is fine. Do you use drains for tummy tuck procedures? If no, where does the fluid/blood go? Good question. Now, for tummy tuck procedures, I do still use drains. It's one of the few operations I use drains in. I think as general terms, we are moving away from using drains, but tummy tucks is one of those ones that I do still use drains for. And the reason I use drains is because there's what's called a dead space there. There's a space there, and the drains are what's called suction drains, which means they've got constant negative pressure. And that negative pressure sucks the space down to make it stick together. And so the worry is that if you don't suck it down and make them stick together, that you might get some fluid collection there known as a seroma and hematoma, but hematoma less so. Hematoma is blood collection, which can happen after an operation. And to be honest, that can happen whether or not you use drains. The main reason I use drains is to close down that dead space and reduce the risk of a seroma. Now, if no, where does the blood go? So for a lot of operations like breast lifts, breast reductions, etc., or at least smaller breast reductions, I don't use drains. And you might, and I understand what you're saying, say, hold on a minute, if you're going to use a drain, the day after a drain, you can see stuff in the bottle. So if you don't use a drain, where's that stuff going? Well, the stuff just gets resorbed, number one. So a bit like when you bang your arm and it all swells up, it gets resorbed by your body. But number two, the presence of the drain can irritate the tissues and cause it to produce more stuff. So actually having a drain can potentially cause it to drain more, sort of, unfortunately. So yeah, first of all, the body will resorb it. And secondly, I think there'll be less stuff if you didn't have a drain. So I think the presence of the drain does cause stuff to come. Miss Karina Bin, is it normal for an implant to cause a sound in the armpit when the arm is dropped down quickly? Is this a sign of implants placed too laterally? Is it something that could be improved with capsulorrhaphy? I tell you what, Miss Karina Bean has swallowed the plastic surgery textbook. Capsulorrhaphy. I think that's spelt right as well. Capsulorrhaphy, is it double L? Could this also improve me? Crikey O'Reilly. Miss Karina Bean. In answer to your specific question, which is around the sound, No, I don't think so. Yes, the sound is normal. It is normal to get sound when you move your arm. You get sound, and it's an air fluid interface. And presumably, it's shortly after having surgery. So, shortly having surgery, you get an air fluid interface, and you get squelching and what are you calling it? Just a sound, yeah. Just a sound, yeah. That's fine. So the sound is fine. The laterally placement of the implants is more of a physical thing. So do they look like they're too laterally placed? Is your cleavage too wide? So if that's the case, then well, maybe then they are placed too laterally. And if they're placed too laterally, then yes, they could be improved with a capsulorrhaphy. So a capsulorrhaphy is where you stitch the capsule together, you close the capsule down. So the capsule is scar tissue forming round like a farting sound. Yes, very good. Yeah, basically. Oh, years later? No. Oh, years later? Oh, crikey. No, Miss I'm talking about like the first week or two after surgery. No, that sounds a bit odd, Miss Karina Bean. I think you need to go and see a surgeon. That sounds odd. But I don't really know what's causing that sound years after surgery. So specifically for the sound, I'm not sure if a capsulorrhaphy would help that. Now, if you feel that your implants are too placed laterally and you haven't got a very good medial cleavage, then you could medialize them. You could bring them medially and close down the space laterally with a capsulorrhaphy. Air trapped in the armpit. It's not the usual air inside. Yeah, I mean, when you do surgery, Miss Karina Bean, you do get air trapped inside, but that air gets resorbed after a week or two. You don't get air. Air won't stay. You won't get a pocket of air staying there years later. You can't create an air pocket inside the body. If you put some air into if you sort of opened up, made a space and closed it and trapped air inside, that air would get resorbed. It wouldn't stay there forever and cause a farting sound. That wouldn't happen. So I think it's a bit unusual that you're getting that years later, got to be honest. And often it's the air fluid which cause a bit of sort of farting sound, a bit of like a sloshing about type sound. So I think that sound is a bit unusual, Miss Karina Bean. I would go back to see your surgeon and talk to your surgeon about that, because that does sound unusual. But the I can envisage the sound, but I don't know what's causing it years later. It shouldn't really be a vacuum or a space there. The only thing I would say about the lateral capsulorrhaphy to medialize your implants is you've got to look at your shape of your breast, and you've got to look at your nipples, the position of your nipples, because what we try and do is you try and centralize the implants on the nipples. So sometimes people have got a wide, laterally spaced breasts and a wide cleavage naturally. So you've got to look at your pre-op state. So if your implants are actually centered on your nipple, you've got to be a bit careful, because if you medialize them and try and make the cleavage look better and move those implants medially, if they were centralized on the nipple before and then you medialize them, that nipple can look lateral. That nipple can look like it's weird. It looks like the nipple's spaced laterally, when in fact you haven't moved the nipple, you've just moved the implants. So by moving the implants, you've got to be a bit careful, because you can make nipples look too high, too low, two to the side, two to the middle, just by moving the implant, if that makes sense. So if your implant's sitting too high, your nipples can look like they're sitting really low, and then you move the implants down. But if you move them too far and move the implants really low and your nipples are at the top of the implants, it looks like your nipples are sitting high, when in fact your nipples haven't moved. Does that make sense? And it's the same with the medial lateral. We try and centralize the implants on the nipples, or the nipples on the implants. Anyway, so that's something to bear in mind if you are thinking of medializing your implants. I have too much side boob, hence the noise when my arm hits off it. So too much side boob, yes, medializing would help, but as I say, you've got to see if they're centralized on the nipple. If they are centralized on the nipple, then that would suggest to me maybe the implant's a bit too wide. And that's one thing that I'm very keen on, is not putting implants in that are too wide. So if you do feel like you've got too much side boob, is too full laterally and your arm's hitting it, then that is a problem with putting implants in too wide. And that's something I'm very careful about, making sure that the diameter of the implant is correct, the width of the implant is correct. So as I say, it might be placed too laterally, in which case medializing would solve all your problems, because you wouldn't have that side boob. Well, maybe not the farting sound, but it would solve the lateral fullness, and it will medialize the cleavage. But if they are actually centered on the nipple, it might be that you'll need a narrower implant. But if you have a narrower implant, the width of your cleavage will get wider. So it will not help the medialization problem. So yeah, that was so great minds, Miss Karina Bean. Great minds think alike. Tricky problem by the sounds of it. Oh my God, Alexandra says, evening. We've got another person commenting on YouTube. Hi, Alexandra. This is new to me, having comments on YouTube, and Pratic has started it. So thank you, Alexandra, for continuing. We've got 2 people commenting on YouTube. That's 1,000% better than ever, because I don't know if anyone has commented on this before, but that's really good. Excellent. Thank you. Good evening. Very excited about that. So yeah, Miss Karina Bean, we got great minds think alike. So yeah, tricky problem, Miss Karina Bean. You need a surgeon to have a look at that. So preferably your surgeon, because you must have a surgeon because you've got all these things going on. So good luck with that. Good luck with that. Do you prescribe antibiotics post-surgery? No, I do not. Well, the only one that I do prescribe antibiotics for is fat grafting. I do give 5 days of antibiotics for fat grafting, but for everything else, breast implants, tummy tucks, breast lifts, you name it, thigh lifts, arm lifts, I give 1 dose of IV, intravenous antibiotics on induction in theatre, and I don't give any post-op antibiotics because there's no evidence to say that it's good, that it reduces your risk of infection, and there are problems with prescribing too much antibiotics. So I just give 1 dose IV in theatre, and I don't give any post-op. I am aware that some people do give post-op, but it's not based on evidence. I think it's based on how they feel about things, which is fine. But that's just how I've always done it. So yeah, that is me. Right, I'm out of questions. Oh, that was quite long, wasn't it? Good one though, Miss Karina Bean and Danny. Yeah, Miss Karina Bean and Danny did well. Pratic, good on you on YouTube. Pratic has started something on YouTube, guys. I think I'm going to blow up on YouTube. I see my children with these YouTube videos with millions of views, and I feel like I'm going to be there one day. And they're rubbish, honestly, rubbish. Playing some stupid hide and seek type game, Minecraft, a load of old rubbish, and they got literally millions of views. For goodness sake, this sort of stuff that I'm doing, I keep on telling them they should be watching this stuff. Maybe not specifically this stuff, but this is anyway. Biding my time. Pratic and Alexandra have started on YouTube. Jackie says, great Q&A. Thank you, Jackie. You've been here in the beginning, Jackie, before I was a YouTuber. Look at that. Two people commented on YouTube, Jackie. Miss Karina says, oh, Danny, you got a question. Oh, Danny's got a question. If taking immunosuppression, does this continue over surgery, or do you advise to stop? Good question, Danny. I'm sorry, I don't want to be evasive, but I'm going to say it depends. Immunosuppression will reduce your risk of wound healing, reduce your risk of wound healing. That doesn't make sense. Reduce your ability to heal your wounds, and it will reduce your ability to fight infection. So increases your risk of infection, increases your risk of wound healing problems. So immunosuppression is bad from a surgery point of view. We don't really want to do surgery on people who are immunosuppressed. So if you are immunosuppressed, we'd have to talk to the person who is dealing with your immunosuppression to say, does she need the immunosuppression? Is something really bad going to happen if we stop this? Depends on what you're on as well. Steroids and things like that aren't good for surgery. So can we stop this and get you healed and then start it again? Or is that going to have some kind of catastrophic result on whatever you're on the immunosuppression for? In which case we'd have to say to you, look, either don't do surgery because you've got a really high risk, or say to you, look, you've got a higher risk than normal because we can't stop your immunosuppression. Do you want to go ahead with surgery or not? Because you've got a higher risk than most people particularly in terms of infection and wound healing problems. So I can't give a blanket answer, but basically if we can stop the immunosuppression, it will be better. But we'd have to do that with the blessing of the person who's put you on the immunosuppression, because they might say, for goodness sake, it's going to be really catastrophic if she stops it because she's got this really bad problem. Yeah, azathioprine and prednisolone. That's pretty hardcore, Danny. I've got to be honest with you. That's pretty strong immunosuppression. So we don't want to stop your immunosuppression and get a flare up of whether you've got an autoimmune disease or whatever the problem is that's requiring you to have immunosuppression, we don't want to get a flare up. But they say, oh yeah, stop it and we'll do your breast augmentation, and then you get this terrible thing, and then your doctor who's looking after your immunosuppression says, why the heck did you stop that? So we'd have to work together. Yeah, work together with your rheumatologist or whoever it is looking after your immunosuppression, and just say, hey guys, what can we do? Can we stop it? Can we optimize it? So if we can't stop, the surgery can't go ahead. I'm not saying that, Danny. I wouldn't say that blanketly. I would say that if we can't stop the immunosuppression, you're going to have a higher risk of wound healing problems, and you're going to have a higher risk of infection. And obviously it depends on what surgery we're talking. Do we know what surgery? You said earlier what surgery you were talking. Is it mummy makeovers and things you're asking? Because that's quite a big deal. So, if you're talking about breast implants, particularly, as I said earlier, we really do worry about infection with breast implants. So that is a big deal. Tummy tucks, big wound healing problems, etc. So it would need a discussion, Danny, between yourself, your surgeon, and your physician looking after your immunosuppression. Yeah, mummy makeover, that's a big deal. So I'm not going to say no, but I'm going to say maybe not, because you're going to increase your risks. And so it might, depends on how. It's like, who was it earlier on saying I'm worried about infection? Were you there right at the beginning? Someone said I'm worried about infection with breast implants. It's a risk-benefit thing, It depends on how much the benefit's going to be. Your risk is higher than other people, so you're going to be less likely to go ahead with surgery than someone else, all other things being equal. But you might feel that your benefit is really, really high. So that brings you, that brings the balance back, because your risk is going to be higher than a normal, I shouldn't say normal, than a non-immunosuppressed person. Your risk is going to be higher, but you might find that your benefit is going to be massively higher. So then, because this is terrible, or you might find actually, it's not that bad. I don't really want to get an infection, and I don't want to have wound healing problems, and etc. etc. It's what it's all about, Danny. There's no black and white. Unfortunately, I think a lot of patients would prefer it if there was more black and white in this, and just say, oh, you got to have this, you got to have the implant above the muscle, you got to have this implant, you got to have that. To be honest with you, a lot of this stuff is opinions, experience, and a lot of it we talk to you about it, especially these days. These days we're a lot more, a lot less paternalistic, and a lot more, what's the word, talking with the patient, making a plan with the patient. And like people saying, I've got a 23 centimeter nipple to sternal notch distance, and people getting really involved with their surgery. But we're encouraged to do that, to empower patients to make decisions about their health type thing, rather than being paternalistic and saying, I'm not operating on anyone who's immunosuppressed. We just say, well, you know what, got a high risk. You slipped that one in, Danny, last minute. Oh dear, I genuinely do think I need to lie down now. But thank you all, Danny and Miss Karina particularly, but not on that. Pratik, let's not forget Pratik on YouTube, and all the other contributors this evening. Thank you all for contributing. That's how you say it. And I'm going to check out, basically. But if you've got any questions, post them here. Post them somewhere. On Facebook, on Instagram, on YouTube, on whatever. Message me. And I'll answer them. Simple as that. That's how it works. So I will see you this time next week. Katie Adamthwaite has just arrived. Get the numbers up, Katie. Big up yourself. Well done for arriving. I'm shooting off now, but I'll tell you what, you watch back. It was a belter. You're going to, God, 11, Charlie 11's just, God, everyone's arriving now. Look at this. The numbers are swelling, honestly. But yeah, if you want to learn about plastic surgery, guys, you look at the last, however long we've been here. How long we've been here? An hour or something. It's been a roller coaster. But thanks for coming. Thanks for these hearts that are coming. I don't know if that's Drag or if that's someone else, but whoever it is, thank you for that. I am going to go and put my feet up, and I suggest you do likewise. But until next week, I'll be here 7 o'clock, fashionably late, like your style. That is cool, man. Yeah, I don't know about that. I'm always very early myself. Anyone who knows me, I'm always late. So, but thanks for coming. And I'll see you next week. And I will stop that one. Stop the stream. Stop the stream, and I'm going to exit here.